All right, we're going to get into our next session, which is going to be focused on advancements in telemedicine. And Marc Newell is going to be the presenter for this. Marc Newell is a non-invasive cardiologist at the Minneapolis Heart Institute. Dr. Newell did undergraduate at Gustavus Adolphus College Medical School at the University of Minnesota, and residency training included as the chief resident at Abbott Northwestern Hospital. He completed training in cardiovascular disease at the University of Minnesota and served as a chief fellow. Dr. Newell currently serves in several leadership roles with MHI. These include being chief of clinical cardiology, medical director of MHI United, medical director of MHI Teleheart program, and is one of the vice presidents of MHI. He is also honored to serve on the board of directors of the Minneapolis Heart Institute Foundation, the research affiliated with MHI. His clinical focus is on patient care, systems of care, advanced cardiac imaging, including cardiovascular CT imaging, and his practice sites include many locations: Abbott Northwestern Hospital, Edina Centennial Lakes Clinic, and Ridgeview's 212 Medical Center. In both 2019 and in 2020, Dr. Newell was named a top doctor by Minneapolis St. Paul magazine. Looking very forward to hearing this session myself. Here is Dr. Newell with advances in telemedicine.
Good afternoon, everyone. Welcome to the Rock from the Heart. My name is Marc Newell. I'm a general cardiologist with the Minneapolis Heart Institute at Abbott Northwestern Hospital, and thrilled to be a part of this conference, so thanks for having me. Today I will focus on talking through telemedicine and how telehealth has had an impact even before the pandemic, but especially with the pandemic, and how we can leverage this tool to help care for patients as we move forward. So thanks for being a part of this. So the focus of today's talk will be on several things. First is why even consider telemedicine, especially why I consider telemedicine in cardiology and in aortic patients, and how can it really apply to cardiac patients? I have two buzzwords, if you will, for telehealth and how it applies, which are access to care, and triage, our ability to assess who needs care quickly and where do they need it. So trying to sort of right size people's care. And I want to walk through what are the tools that we currently use, what's currently available, what will be available hopefully to us in the near future, and certainly expect this technology to advance, especially how we're able to assess patients in a faraway clinic or even in their own home. And then talk through some future models and opportunities for telehealth and for cardiology in general. So hopefully it'll be a fun, engaging discussion. And again, I appreciate being here. So some of the advantages to doing telehealth, especially specific to cardiology, many advantages. If we think from a patient-centric lens, the key is access to specialists. So ideally getting the highest quality care from the specialist you need right in your own home or in your own clinic, if you're in a rural setting, is really ideal for patients. We often underestimate, especially as providers, how far patients have to go to come see us as specialists, or also how much their family has to give up to have the patient come and see us, meaning they may have to take a day off, they may have to travel and pick up their mom, grandma, whoever it may be. And so it can really have a big impact, not just on the patient, but also on the patient and their family. So the ability to minimize travel, bring that expertise to the patient is the really essential essence of telehealth from a patient standpoint. Also, it is cost savings when you think of the travel and everything else that goes into those visits. And the cost of doing telehealth visits is covered by payers, and is also, if something that people have to pay for, is the same as an in-person visit. So it's not more expensive, and again, more convenient and closer to home means it should be a cheaper process for patients. So why, from the specialist standpoint or from a health system standpoint, would you want to consider telehealth? Well, in the same vein, it really saves time and travel for your providers. It's hard to get to many rural locations that have a small population to say it's, quote unquote, worth it to send a specialist to one of these small towns to see a handful of patients when they could be in the hospital or in a metro clinic seeing many more patients. So it helps with some efficiency for the health system to be able to see more patients from more locations at the right time. That allows expertise to be expanded across the whole spectrum and again, to rural locations. I think it's pretty clear that we're facing a physician shortage. We're not training enough doctors, but also the number of patients that need our care is ever expanding. So those two issues are heading in the opposite direction. So we need to be smarter and be more efficient about how we're able to leverage, especially our specialists. And I think from a specialist and a health system standpoint, this is absolutely a great way to enhance partnerships with some of our rural clinic sites, as well as form new partnerships. Our program started in 2014. We have 4 new sites that are part of the MHI team simply because of the ability to access telehealth. So it's been a nice system for us as well from a partnership standpoint. When you look at the impact across the entire care spectrum, I really want to emphasize that telehealth is possible because of technology, but it's really not about the technology. It's all about relationships. Again, it's all about the access to care and being here for patients. We can feel this benefit again across the spectrum. As I mentioned, the patients hopefully get the highest quality of care. They get the specialist they need close to home. So the phrase is the right patient, right time, right place. For the local clinic sites that we've started these relationships with or enhanced the relationships with, they have more opportunities to provide more care for their patients, which of course we'd love to keep care local if that's the right thing for the patient and the right thing for the rural site. They have more specialists available more often with telehealth. And again, for the specialists involved, it's more visits, more quote, right-sized visits, seeing the right patients at the right time in really any location. So in 2017, the American Heart Association wrote a very long paper policy statement, which is listed and referenced here, with the quote that I thought was very interesting and accurate, in that telehealth is critically important in the future of cardiac care, both to reduce the burden of disease and costs. I think this is spot on. I think this is an opportunity for us to be smarter about how we provide care that can reduce costs for patients and health systems, keeping patients local when they can and should be kept local, when all they need is just that little bit of expertise from a specialist, which they wouldn't be able to get in their local facility unless there was a program like this. That absolutely saves costs. Burden of disease, being able to get those specialists to help care for patients wherever they may be, can certainly reduce the burden of disease. What was most interesting to me was that this was published in February of 2017, and they had absolutely no real-world programs or data to really back their whole policy statement. So I thought it was very forward-thinking of them to put this out, but just to speak to how new this is, they really had nothing to reference in terms of real-world experience. So I mentioned that we started our program in 2014. So we started doing a clinic-based telehealth program in cardiology in 2014 with several key partner sites. We were able to really give the AHA something to go with in terms of a real-life experience by publishing our experience in the Circulation Cardiovascular Quality and Outcomes Journal in 2017. So this reference is there for anybody that would like to look this up. It was a hopeful paper to really discuss sort of the pearls and pitfalls, if you will, of developing our program, what the benefits were, which I just mentioned, but also, you know, what are some of the things that people need to think through as they start their own programs, with the hope that really this is something that could be modeled and mimicked and improved upon as other places move forward with a program like telehealth in cardiology. One thing that you'll often hear referred to, especially in administrative circles and in medicine, is the triple aim. And actually, they've tweaked this recently to the quadruple aim. And so the triple aim is patient experience, improve the health of populations, and decrease the cost of care. The fourth in that quadruple aim is also the physician or provider experience. And so when you think of telehealth through that lens, it really does apply in all cases. And if I'm repeating a few points here, forgive me, but I think it's important that we drive home a few of these points of how telehealth can really be beneficial. So from a patient experience standpoint, again, it's all about access, back to those buzzwords. The ability to access care, access specialists, access those close to home without having to travel, without having to make that decision in their own mind or their family's mind, well, is this really worth it to go to this visit or not? Or can I just do this close to home? being able to provide this close to home is a huge win for patients and families, easier access to care. When you think of the health of the overall population, access is really essential here as well. If you can get timely access to the specialty providers and understand, okay, yes, I do need something further as a patient, or no, I'm actually good on the medications I'm on, or I can do, these next few steps and things will be okay. That's a great way to make sure that the whole population is getting the right care that they need in a timely fashion. This is also a way with telehealth to do this without necessarily saying we need a ton more providers. It's a way to really enhance, again, the efficiency of the providers and specialists that we have now to get to more patients at the right time. In terms of decreasing the cost of care, we mentioned already that the ability to keep people local if that's appropriate, or to transfer them if that's also appropriate. Sometimes it can go both directions where patients maybe should have come in sooner. And this is really where that triage buzzword comes in. If we can be better as an entire community and medical system about getting patients to the right place at the right time, that will save tremendous amounts of cost and obviously stress, and hopefully provide better care as well. So if you think through an example that came to me before we had our telehealth program in one of our rural sites, I had a patient who had been having chest pain, had a stress test. The stress test was abnormal. The patient had heard that and was really given the choice of, well, you can see me at New Ulm, but we don't have an appointment for 6 weeks, or you can drive to the Twin Cities to get your appointment sooner, which is a 2-hour drive. The patient, of course, not knowing exactly how bad the stress test looked, chose to wait. And so here I saw him almost 2 months after his chest pain and stress test, which was quite abnormal. And luckily nothing happened to him, but that's just one example of where this patient really should have and could have been guided sooner to say, you know what, this is a test that should be addressed right away. Let's see you right away this week over telehealth, and we'll get you into your angiogram. Again, just one example. There are many examples, again, both directions, but if we can decrease some of those transfers that don't need to happen, but also get those patients that need to be somewhere urgently there sooner, then we're providing better care, and we're decreasing the overall cost of care for the whole health system. So looking specifically at our program that we've developed, this is a site map of obviously all of Minnesota, and based on the Minneapolis Heart Institute's outreach program. When you look at that kind of zoomed in box there on the right of the screen, that's obviously the metro area locations. Those that are depicted in red are sites that we go to every day and have cardiologists 5 days a week, as well as imaging services. We have a few partners that live in the Brainerd, Baxter, Crosby area. That's why those are red. But importantly for this talk, if you look at all of those sites, you can see there's a big site and a big geographic area, but all the sites that have the little green flags that say TH for telehealth are sites that we actually offer clinic-based telehealth consultations to. You can see it covers most of our outreach sites. These are sites, some that have been long-term partners since 2014, some that are relatively new. And as an example, I pointed out places that have just joined us just for telehealth, and that would include a place like Pine City, north of the Twin Cities. These locations, again, get extra access to care. They get a chance to have telehealth patients seen, whether it be every week or every other week, as an enhancement to their current relationship with our outreach providers that go physically on site. Some of these locations we go on site weekly, sometimes more, sometimes less. But this is, again, additional access for those patients. So it gives you a sense of sort of the scope of the program. One thing that's been also really neat, I mentioned about specialists, which cardiologists certainly are. The whole world, especially in cardiology, has gone very much even to subspecialization. So I have partners that deal almost exclusively in the electrical space of pacemakers, devices, defibrillators, atrial fibrillation, arrhythmias. I have partners that deal mostly with patients with really bad heart pumps or advanced heart failure that need potentially even heart transplantation or mechanical devices to support their heart pump. So there's so many niches now in cardiology, and this of course includes our surgical partners, vascular surgeons, cardiothoracic surgeons that do open heart surgery. Oftentimes patients certainly need these consultations that may be hours away again, and back to those points of access and triage, their ability to be able to have access to a surgeon, to be able to understand, do I need a surgery? And if so, is it urgent? Is it not? Is very helpful, just as one example. So this has really been a really helpful thing for our patients, and certainly for our system, to be able to even offer these subspecialists to say, yes, this is the expert in your problem, and they are happy to see you over telehealth and advance your care that way. So when we first started the program, going back now 7 years, we were really looking at patients that were new patients to the program, or patients that had an urgent need. So somebody with a new symptom change, new chest pain, new issue that's not necessarily needing to go to the ER, but needs to be seen by a cardiologist quickly. What we've learned over time is that there are many, many patients, of course, that need to see a cardiologist. And this is a great tool to leverage in other situations. A couple of examples, and one specific potentially to the aorta, is anybody that's had an aortic surgery should be followed up very closely after they go home from surgery. Same with somebody that's had a heart attack or an acute coronary syndrome, somebody that's been in the hospital for heart failure. You can imagine that being in the hospital is sort of a whirlwind for patients. They've got all these people coming in and out of the room. They get variable descriptions of what happened to them and what the next steps are. And so when patients get home, oftentimes their focus is, I just want to get home. And once they get home, they say, well, wait a minute, what are these new medications, and why am I doing this? And oh, I forgot to weigh myself if I had heart failure. All sorts of things can go a little sideways based on how difficult sometimes it is for patients to transition back to home and understand why changes were made. Because of that, the American College of Cardiology has actually made it essential that patients, especially with a heart attack or a heart failure admission in the hospital, should be seen within the first week after they're discharged. The rationale is mostly educational. Here's why you're in the hospital. Here's what happened. Here's why you're on these medications. You need to weigh yourself. You need to do X, Y, and Z to make sure you're well taken care of. Also, we see, especially in those two populations of heart attack and heart failure patients, they get readmitted to the hospital very frequently in the first month after they were admitted the first time. This is extremely unfortunate for patients. They don't want to go back to the hospital. It's also extremely costly for the health system. So that's the reason why a lot of these things have been put in place. So how does that apply to telehealth? Well, if you're living 2 hours away from a metro hospital that you were just admitted to, about the last thing in the world you want to do 3 days later is to drive another 2 hours each way to go back and say, yes, you're feeling fine, just take your medications. And I obviously oversimplified that a little bit, but I think you get the point. The whole goal is to say, we want to educate, we want to help understand why you're in the hospital, do all those things that I mentioned about here's why you're on these medicines and so on. And that can easily be done over telehealth. Those visits can give a good visual exam. There are certain stethoscope elements that we can use to listen to the heart rate, make sure there's no new funny rhythm or other issue. And then again, essentially be able to recreate why they were in the hospital, what the next steps are, and why it's important that they take their medications, check their weights, and so on. So telehealth has really been leveraged in this space a lot, especially in our program, and especially in that heart failure space. And we've seen a significant improvement in our readmission rate for heart failure specifically. So again, above all, when you talk about selecting patients, I would recommend people not to limit their patients that they see with telehealth, because you really can facilitate a good exam. Oftentimes patients have had a lot of objective data like echocardiograms and other imaging studies, where really what's most essential is that conversation about here's why we're doing what we're doing, here's what you need to be educated, here's what your next steps are. Those are the key pieces of keeping people well and keeping them out of the hospital. So above all else, telehealth is really an access and a triage tool. So just as a sample of our patient access, 2 of our first sites were New Ulm Medical Center, which I mentioned, and Blue Earth Medical Center. When we started the program, again, one of the rationales for starting this program was exactly that patient example I used earlier. Somebody waiting 6 weeks to see a cardiologist, not knowing that they were sitting on a very abnormal stress test, was unfortunate. And so now that we've instituted this program, our wait times for any visit in New Ulm are less than 2 weeks, as opposed to being almost 6 weeks before. In Blue Earth, where we go less frequently, it's further away from the Twin Cities, was almost an 8-week wait in 2014, and now has weekly opportunities for patients to be seen. So again, this is the essence of telehealth and the ability to get patients treated, screened, and cared for in a timely fashion. So just briefly, I'll talk about whether or not this works, whether the program has grown, and it certainly has. We actually have grown in the number of patients that we've seen, the number of sites we have, as I mentioned, and even the number of states that we've served. When you look across our system, our traditional outreach clinics where we physically go to a clinic and see patients, we see about 1 out of 5, 1 out of 4, 1 out of 5 patients that are new patients. With our telehealth program, we've seen almost half of the patients being new patients. So to the point of access and triage, we're drawing patients that need us urgently or more urgently. So patients that have a new problem, they have a new symptom, they need to get in. These are the patients that we tend to see with these telehealth programs, again, by having better access. In the first 6-7 months of the program in 2014, and it was started in the early summer of 2014, we saw almost 100 patients that first half year, which was excellent. We saw almost 1,000 patients at those sites that I mentioned in 2019 before the pandemic. So this program has clearly grown. There's clearly a need for it. It's a well-used tool, and I'll get into some of the feedback from patients that has been actually very good. As I mentioned, we've had new sites that have come. The one in Naples, Florida, has since gone, but opportunities to provide care in Fargo, North Dakota is a great example. Some great doctors, great health systems in Fargo, but do not have access to advanced heart failure care, like those patients that really are sick and need potentially heart transplantation. Our heart failure team has been able to access those patients, be able to care for them and allow them to stay the 4 hours away that they are, if appropriate, and again, understanding if they do need to come down, that they'll get a high level of care and that they really need to be transferred. I think most importantly, when I helped to start the program in 2014, I was quite worried about how patients would receive this and perceive their visits. Oftentimes in cardiology, we're talking about patients that may be in their 90s, their 80s, their 70s. And this, again, 7 years ago was before we're all so used to technology, as we've learned, especially with the pandemic in the past year. But what we did with all patients when we first initiated the program was we had them do a pre-visit survey. So are you worried about the visit? Are you worried about the confidentiality? Are you worried about the technology? And then did a post-visit survey with the same questions. As you can see, patients really received this program very well. They were very willing to recommend it to others. They felt that the care that they got was as good, if not better, than an in-person visit. And I think a lot of these percentages that you're seeing, maybe a little bit Minnesota nice, but I think it's also, again, just emphasizing that these patients were relieved to be able to get care close to home. They're going to the clinic that they already know and love and are comfortable with, but they're also understanding that being able to see the specialist close to home is a big win for them. So it's nice to see that patients have received this well, but again, opportunities to see how we can serve patients better. Certainly 2020 was a crazy year, as everybody knows. It really, I think, stretched a lot of people and was a tough year for everybody to get through in many different ways. Importantly, though, as you look for silver linings, what did we learn? What can we learn from something like the pandemic? We certainly had to switch gears in terms of how we deliver care for patients. A lot of what we did right away when it wasn't safe to be in clinic or wasn't as safe to be in the hospital seeing patients was to leverage the ability to do these video-based visits, to use things like our electronic stethoscope, some of these tools that we'd worked with in our program to say, how can we still provide the best care while keeping a safe, physical distance at times. And so we did transition quickly to both virtual phone visits and virtual video visits, whether it be over a platform like a Zoom or a Microsoft Teams. We're able to facilitate some of those visits. We still were able to get patients back into the clinic for the formal exam after a few months into the pandemic. But again, it really kind of maybe helped us glimpse into the future as to what are the possibilities. When you think specifically to cardiac or cardiovascular patients, one of the tricks is how do we get a good exam? How do we get good objective data to really help us make the right judgment for the patients? As I mentioned before, there are many tests available in many locations. So things like, echocardiograms, which are ultrasounds of the heart, things like blood flow screening of the legs. Some of these things are really available everywhere. So having some of those objective things done even before a visit like this can be very helpful. But as we switch gears and think towards the future, we already have home blood pressure cuffs. There are more and more evolving home rhythm monitors, whether they be wearable technology or other devices. There are programs that are being worked on to consider even, quote unquote, smart probes for ultrasound, probes that can actually have a novice patient really take pictures of their own heart and potentially send those on. So I think we're just scratching the surface of this. I can picture a world in hopefully 3 to 5 years where we have a lot of this available to us. And if the patient can give us subjective data about their blood pressure, about their heart rhythm, about even their heart pump function, boy, we can do a lot from when the patient's even in their own home and when we're at a distant location as the provider. So again, scratching the surface of this, the pandemic had some silver linings, especially about how we're able to really extend care for patients and think differently about how we care for patients. And so this has been really an interesting part of what happened over the last year. Just to give you an example of this, that ultrasound piece I mentioned was something that we really thought through early on in the program, and blessed here at Abbott Northwestern to have a really strong ultrasound program that's taught to the medical residents and to others. So there's really a robust program about using the probe to do ultrasound-based images, and we thought, boy, this is a great opportunity to streamline this into our visits with telehealth. It gives us more objective data, gives us more information than a stethoscope would, and it's a very exciting part to add on to the exam. So we trained our first few nurse practitioners that were facilitating the visits, and again, working towards some of those smart probes that can help even a novice understand if they're getting a good picture. But with an ultrasound alone, we're able to answer very important questions very quickly. Is the heart pump normal? Is the heart pump very weak? Is there fluid around the heart in the pericardium? Are the valves okay, or are they really bad? So we may not be as specific as echo and some of these other things that we do for tests, but it's a great screening tool. It gives good and objective information right up front. And again, I can envision in the not so distant future this being something that's universally available, and again, potentially even at kiosks or at people's homes. So just to give an example of what this looks like, this is just an exact sample from one of our early ultrasounds. And you can see here, I'll play it again. This area here is the left ventricle, the pumping chamber of the heart. Here's the aortic valve, and there's the aorta, which of course is our focus here. This is the right side of the heart, and this is the left atrium. This is just simply a probe up against the chest wall. When we want to hear things like the heart rhythm, we can hear that with our stethoscope. We can't tell if the heart pump is normal or not with the stethoscope. We can see potentially signs of heart failure, but we don't get this good of information if we just listen, even with an electronic stethoscope or an in-person stethoscope. So again, ability to enhance potentially what we can already learn, even though the provider is distant from the patient. So this is all, again, potentially the future of where we're headed with telemedicine. So I think as we think through what are some future directions for telemedicine, there are certainly models that we've already thought through, and again, the pandemic changed our thinking in certain ways. The ability to see patients that truly need us that day. They have a new heart problem. We want to evaluate potentially patients that are in the hospital if we feel like we can supplement the care of that local rural physician who may not have as advanced cardiology training. Can we help? Can we support? Can we help ER physicians, especially in the middle of the night, get the patient to the right next step, whether that be just a test and staying at the local hospital, or whether that is the patient needs to be transferred. This is a great way for patient care, importantly, but also even for health systems. I think places, other systems I've been exposed to, in this work across the country have used this tool as a way for nurses or nurse practitioners or physician assistants to be able to do rounding on cardiac patients in small hospitals, and then they connect via telehealth with the cardiologist at the bigger hospitals. So essentially the patients, even in those smaller hospitals, are getting real-time rounding even on weekends and getting good care. Again, I think the future of telemedicine is to be in the patient's home and to be traveling with the patient as they travel. And so how we can facilitate those exam components in cardiology, I think, is something we should think through. And I think also the learning from the pandemic is that, sometimes those virtual video visits work just great for that stable patient that just needs follow-ups, just needs a review of their labs or whatever was done. Those patients may not have to come into the clinic. It may be a hassle for them to do that. So can we, again, right size? Well, you'll need to come into the clinic every other year or every third year, but those intervening years, let's just do a quick visit over these type of technologies and see how you're doing, and see if we need to do something else. So it may be a convenience thing for patients and, again, a savings thing for the system. I think further incorporation of again, objective data, ultrasound, wearable devices, patches for heart rhythm, blood pressure, and again, the ability to be right where the patient is, whether that's in their own home or as they're traveling, the ability to see a specialist whenever you need it is essential. So thanks again for the time. Thanks for joining the Rock from the Heart session. I really appreciate the opportunity to be involved. So in summary of my talk, telehealth is absolutely a key initiative in specialty care as we move forward into the future. It can really help providers triage patients appropriately. And again, from the patient standpoint, it can help them be in the right place at the right time. It can help patients gain access to specialists. It can help providers in rural locations have access to specialists. It is a great tool, again, potentially for patients even as they travel. I think it's essential that we were able to show that you can grow a program, that there's absolutely a need for this, and that patients receive this program well. And again, we're just scratching the surface, and we learned so much in the past year about how to provide care in different ways and think differently about how best to provide care for patients. And we're constantly learning, so we're always open to new ideas and new suggestions. And I think this will continue to evolve as we move forward. So I'm excited for it. I hope you are as well. And again, thank you for your time and attention. I really enjoyed being a part of the program. Thank you.